Good afternoon. Thank you, respected chairpersons. At the outset, I must express my gratitude and thanks to Dr. Arun Garg and his team from Medanta for inviting me and giving this opportunity to talk to you and discuss about one of our own projects and one of our subject of importance, the cardiovascular autonomic dysfunction in patients with PD, which is a neglected portion in the management of PD patients in our routine practice, and there are something which are unnoticed and unwarranted, and these are things which we need to pay attention, and they are quite important, improving the quality of life and in overall management. So there's nothing to disclose. As you know, the autonomic dysfunctions could be varied from in the PD patients, right? From the siluria to the dysphagia to the sweating, the hyperhidrosis, to the constipation, to the urinary problems, to the sexual problems, to the gastric paresis, and of course, the more important, which we are going to talk today, is the cardiovascular autonomic dysfunction. So that is something which is being talked about much more these days, and that will include the orthostatic hypotension, the supine hypertension, which is the more important and more dangerous complication, and of course, dipping, non-dipping, and reverse dipping, which is something which is happening these patients. So today, in next 20 minutes, I'm going to talk about these 5 things, 6 things. The first will be the orthostatic hypotension, then the supine hypertension, and of course, postprandial hypertension, exercise-induced hypertension, post-exercise hypertension, and of course, non-dipping as well as the reverse dipping. So that is what. So all of you know, I don't have to tell you the neurogenic orthostatic hypertension, how we define it, how we measure it. But the more important thing is the patients which have the orthostatic hypotension also have the supine hypertension, which is a neglected part. So having orthostatic hypertension is one component, but measuring the supine hypertension is another more important complication which is unnoticed and often neglected in our practice. So what is supine hypertension? So this is the neurogenic supine hypertension in a proven case is defined as systolic BP of more than 140 and or diastolic of more than 90, measured after at least 5 minutes of rest in the supine position. So that's the standard definition. It could be mild, moderate, severe, depending on the readings and depending on what time of the day you do it. But why we want to know, why we should know about it, because the neurogenic supine hypertension often worsens the orthostatic hypertension. So they go hand in hand, and that is why they often coexist, and that is why they must be measured by 24-hour ambulatory BP monitoring in all patients of Parkinson's disease who come to our clinic, and that is the supine hypertension can lead to acute complications as well as the chronic complications, which are well known for the organ damage, and that is something we need to protect for the early death as well as for the overall morbidity and mortality. So coming to the definition of postprandial is of course decrease in systolic blood pressure of more than 20 millimeter or decrease of below the 90 millimeter of mercury from a pressure of more than 100 within 2 hours after a meal. So that is another entity which should always be recognized and measured, and of course which is a prevalence of more than 1/4 of these patients which are hospitalized, and it can have increased risk if the patient also has comorbid other conditions like spinal cord injury or diabetes or pure autonomic failure. So I'm just running through the definitions and then I'll come to the main crux. The exercise induced is more than 10 millimeter of mercury fall in systolic blood pressure during the exercise. Normally once we do the exercise, the blood pressure increases. But these patients with the autonomic dysfunction, the blood pressure falls, and of course the sustained fall after the exercise is called the post-exercise hypertension. So the concept of non-dipping and the reverse dipping. So normal physiological dipping is when you sleep, there is more than 10% of dipping, and that is a normal phenomena during the sleep. Reduced dipping is when it is less than 10% as respect to the mean daytime BP value, and reverse dipping is when the BP increases, either it does not decrease or even it increases during the night time with respect to the daytime. So supine hypertension is the one of the features of the reverse dipping actually, and that can lead to increased morbidity and mortality. So that shows the normal physiological dipping when we sleep. You can see from here during the sleeping hours, the blood pressure actually goes down, and otherwise the blood pressure is in the normal range. And you have the reduced sleeping when it is less than 10%. During the sleeping hours, the dipping is there, but it is less than 10%. And reverse dipping is when actually the blood pressure goes up during the sleeping hours, and that is something very dangerous and something which has to be recorded. So when we do the normal head-up tilt test in a healthy individual, this is the normal blood pressure charting and the pulse rate while sleeping, standing, or so it remains more or less within the normal limits. But once you have a autonomic dysfunction during the supine position and the standing, once you keep up, the blood pressure goes down, and that is dipping more than expected, and it comes back to when the patient is supine. Now coming to how do we recognize it, how we manage it, what we should be done. So this is something like prevalence studies. More than half of these, many of these patients will have more than half, and there are some patients in the community where you can have older age group, you can have trigger factors, and you can have different things. It can also be defined as initial transient BP fall, or more commonly within 3 minutes, or sustained after 3 minutes also. That is reduction after 3 minutes. The standard definition for 20 and 10 remain the same. But why it happens? There could be cardiac causes, there could be extracardiac causes. It's a sympathetic denervation which causes the failure to rise the blood pressure after the postural change, and that is neurogenic, cardiogenic, and of course non-cardiac causes, and that is very, very important to know. The another thing is failure of baroreceptor reflex. When we stand up, the baroreceptor reflex automatically normalizes the blood pressure by increasing the heart rate, and that is also a failure in these patients with autonomic dysfunction in the Parkinson disease. So these are the common symptoms. Of course, we all know the dizziness, visual disturbances, coat hanger pain, renal hypoperfusion, and of course non-specific weakness, lethargy, and fail. So what are the triggers? Of course, standing up suddenly from lying down position, dehydration, eating heavy meals, warm temperatures, infection, psychogenic, all these things can be triggered, and you can have the fall in blood pressure while standing. It's not going further. Okay. So how do we screen these patients in the clinic? What we do? So either you screen it, you have a normal blood pressure, then you educate the patients with the symptoms of orthostatic hypotension, identify the triggers. If you have a in between where the patient has asymptomatic but borderline BP, then you extend the duration of active standing, or you do the 24-hour ambulatory BP monitoring. If you have a positive screening, that means standing BP falling more than 20 millimeter, then you exclude the other causes, extra neurological causes, non-neurological causes, and then do the 24-hour ambulatory BP monitoring, and then we manage these patients. Either we repeat or we follow up by medications on non-pharmacological patients. So how do we manage? The three pillars, of course, prevention is first thing, then of course pharmacological and non-pharmacological measures, which are equally important. So what can happen actually? So you have to have these non-pharmacological methods. All of you know this. Lot of fluids, increasing the salt, avoiding alcohol, standing up slowly after in the morning, going to toilet. Of course, sitting on the edge of the bed for 2 minutes. That is very simple method, and of course avoiding exposure to hot environment, hot baths, saunas. And the other thing is you can elevate the head of the bed while lying down. Try using a wedge under the reach. You can also do all these physical countermeasures like clenching the fist, crossing the leg and sitting down, leaning forward. You can squatting, putting a leg on the chair, or the brace position, which is the normally what we hear during the plane safety measures, and of course raising the leg end. So that is something which can be done. So what we recommend is actually another thing is the elastic compression stockings up to the level of thigh, or important thing is up to the level of hip or the abdomen. So that is again studied in many studies. You can see abdominal compressions is very efficacious as a non-pharmacological method, in addition to the drugs which we usually do it in case the non-pharmacological methods fail. Drugs you all know, midodrine, fluorocortisone, and droxidopa, and of course sometimes the pyridostigmine is also being used. So these are all drugs, but one has to be very careful by using these drugs. They might increase the blood pressure while standing, but also cause supine hypertension in these patients, and which is again a dangerous outcome or a dangerous complication. So all these drugs are being used very commonly. The only thing is one must take a important message from here, that all patients of Parkinson's disease, particularly mild to moderate, going into advanced, should have a 24-hour ambulatory BP monitoring during the clinic visit at least once in 6 months, and screening BP monitoring lying down and standing in between the visits. So, of course, all these, as I said, these drugs can increase the blood pressure on standing, but also increase the risk of supine hypertension. So, this is an algorithm which we normally use it, either lifestyle measures or non-pharmacology methods, or these three drugs as in terms of increasing frequency. So, coming to the supine hypertension, that is main focus of today's talk, and it has been seen it is more common in these mild to moderate to advanced, all the three cases, but half of these patients who have orthostatic hypotension will also have supine hypertension. So that is very important to see. Mostly both the entities coexist, and particularly if you have a comorbid conditions, the diabetes like this. So that is something which we have been noticing, and we did a small study in our hospital to see how many patients of PD have actually a neurogenic spine hypertension and CAD in the patients with Parkinson's disease, and that study is now in literature. You can access in PubMed, and that is again showing us, I'll show you the parameters. We did the heart rate variability, we did the 24-hour ambulatory BP monitoring, and the particular the demographics are more or less same in other cohorts. But what we actually were surprised to see, out of 50 patients, 32 had supine hypertension. Even those 18 patients who did not have supine hypertension, 10 of them had dipping, and 8 of them had non-dipping or reverse dipping. So that is something, the important message, that many of these patients go unnoticed with supine hypertension, which can be treated and should be treated with all these studies. So why this happens? Again, the denervation of preganglionic with the intact postganglionic fibers leading on to increased non-adrenal levels in the supine position, that causes something abnormality in the autonomic dysregulation in the patients with PD. That is something which you note. Mostly these patients are asymptomatic, but of course the pressure changes, natriuresis during sleep, nocturia, sleep disturbance, volume depletion overnight, and worsening of orthostatic hypertension. All these can be triggers, and something can be identifiable symptoms which we should be vigilant, we should be aware of these symptoms, so that we can get the 24-hour ambulatory BP monitoring for these patients, and that is something important. So all these three scenarios you can see. This one is supine hypertension. While lying down the blood pressure is high, standing still sitting still high, while standing it is normal. So this is pure supine hypertension. While this patient has supine hypertension as well as the orthostatic hypertension. The moment he stands up, the blood pressure falls, sitting is normal, while this lying down, again the blood pressure is high. This patient has a pure orthostatic hypotension. While lying down, the blood pressure is normal, sitting is slightly low, and standing, again the drop in blood pressure. So these all three scenarios, they can coexist, or it can be isolation also. Complications could be, as I mentioned, the strokes and pulmonary edema and myocardial infarction, all the cardiogenic and cardiovascular complications can happen, and they are mainly seen also with the patients of orthostatic hypertension, which are given drugs like midodrine, fluorine F, and droxidopa. And in these patients, you have to be particularly vigilant to identify the supine hypertension. And of course, we have a diagnostic workup chart, whether we do the office in the clinic, or we at the home reading, or we do 24-hour ambulatory BP monitoring, which is recommended now in all patients of PD at least once in 6 months. So that is again a cartoon showing the 24-hour ambulatory BP monitoring. You can see the blood pressure, systolic and diastolic, having a postprandial fall, again during the sleep, going up, particularly patient goes to the loo and then again goes up. And in the morning, the orthostatic hypertension gets worsened. So that is something to be very cognizant of, postprandial hypertension, which I am going to speak in a minute, and of course supine hypertension to be recognized in all patients with Parkinson's disease. So how do we manage this? Just simply non-pharmacological method again. Having a snack is also very important, just going to bed, before the bed. If the patient is already on fluorocortisone, you have to stop it and avoid medication which increase blood pressure like nasal decongestant, eye drops, symptomatics, and NSAIDs. So these are very simple measures. A very important entity, clinical entity, often forgotten, often neglected, which has a treatment. And of course, sometimes you can also use all these drugs. I preferably use hydralazine, which is very commonly used and very safe, so that we can use. Other drugs are also there. Nifedipine, short-acting clonidine, sildenafil, and minoxidil can also be used, and they have been tried in different trials. So these are again algorithm, non-preventive measures, non-pharmacological methods, and of course pharmacological methods, including the drugs which I have mentioned. So this is stepwise approach to treat the supine hypertension, and of course in addition to the which I mentioned as orthostatic hypertension. A few slides about the postprandial, again a neglected entity, a decrease in blood pressure after a heavy meal or a normal meal, and this is again increase in patient with pure autonomic failure with the autonomic PD or with MSA, or patient with having diabetes or spinal cord injury. So this is again 24-hour ambulatory BP monitoring. You can have the control subject, normal subject, and the patient with autonomic dysfunction in patient with PD or other movement disorders, where you see the fall in blood pressure after taking a meal. It can up to the 2 hours. There is a consistent, sustained decrease in the blood pressure. And what are the risk factors? Of course, polypharmacy, more than 3 medication, diuretics, a heavy meal which is rich in carbohydrate, breakfast, hot meals, and alcohol, not to be forgotten. They are all risk factors. And how do we manage? Of course, non-pharmacological methods. Again, avoid alcohol before and after meal, avoid large meals, avoid water and abdominal binders, and of course, the other methods. Having a cup of coffee is also very, very important. It can help in decreasing the blood pressure. So that is where we advocate now these things for the treatment of postprandial hypotension. Of course, midodrine and octreotide can also be used if the persistent unresponsive postprandial hypotension is there. Exercise-induced hypertension, again, you can see normally in a normal controls, blood pressure goes up once you do the exercise, graded exercise. But in case of movement disorders with the autonomic dysfunction, you can have the decrease in blood pressure during the exercise, which can also be sustained after the exercise is over, and that is something we need to be aware of and have monitoring during the exercise and post-exercise, and that is where you can see the pre-exercise, exercise, and post-exercise. In this patient, you can see the post-exercise drop in blood pressure. In a patient with Parkinson disease, early Parkinson is quite young, very active, but has a post-exercise dipping in the blood pressure, and that is very important. Of course, you can have all these recommendations which have been in the literature. Hydration is one of the most important thing, and moderate intensity exercise, not very heavily, unaccustomed exercise, and cool down after booster exercise. So to sum up all these things, you have the neurogenic orthostatic hypertension, lifestyle changes, adjustment of pharmacotherapy. Same thing, supine hypertension, very, very important, lifestyle modification, and of course adjustment of pharmacotherapy. These are the things which are easily done in our clinical practice. The only thing is we need to be aware of, we need to be cognizant of, and we need to have a monitoring of 24-hour ambulatory blood pressure monitoring, or even bedside monitoring of sitting, of lying down, standing, and sitting. These things can identify these patients of having autonomic dysfunction in patients with Parkinson's disease, which is something now we are advocating from our own work. So that is the message from this presentation, that we should have a education, awareness, monitoring, and that is the goal of treatment, is to reduce the occurrence of related symptoms and decline the quality of life. As you know, the PD, the natural history is very heterogeneous. Some patients will have very early decline, some patients will have delayed motor decline, some patient will be responsive, some patient may not be responsive to dopaminergic therapy. Some of these patients, some of the symptoms which are not responsive or refractory to levodopa, and one of these symptoms is the postural hypertension and supine hypertension. I think with this, I'll finish my talk, and thank you very much for your kind attention. I'm open for the questions.